Welcome to Optimizing the Selection of First-Line Therapy for Patients with Metastatic Non-Small Cell Lung Cancer and an ALK rearrangement. This is medical oncologist Dr. Neil Love. For this program, I met with Dr. Justin Gainor from the Massachusetts General Hospital in Boston. And to begin, I asked him about his personal experience with the duration of responses observed with ALK inhibitors in his patients with ALK-positive metastatic non-small cell, and whether he believes some of these patients are being cured.
Good question. I don't think anyone is getting cured. I still think that, patients have disease. And so if we were to stop therapy, I do think that the disease would come back. That said, I do think there's a subset of patients who are their tumors are remarkably sensitive to ALK inhibitors. And even if you think about, there were still some patients, right, at 5 years on the crizotinib arm. The problem is that it was only a small subset, right? And so I think what we're doing is we're lifting that tail up, right? From the 10% now to 60%. What's the lungs? I've had some patients who started on crizotinib 2008, right? They're now on alectinib, right? But we're in 2025, right? So we're already seeing patients have disease for over a decade. I've had some patients on alectinib. I think my longest person on alectinib is 13 years on alectinib right now. So I think there are some patients who are remarkably sensitive to these drugs. Now, what we're really trying to do from a science standpoint is who are these exceptional responders, right? And one of the challenges is if you try going back to the tissue's been exhausted, or there's issues with trying to analyze it. But that is what we really want to do. How can we identify maybe who's the patient who can get away with maybe the most kind of the best tolerated ALK inhibitor versus, we need to blast the tumor.
And any sort of anecdotes of yours or that you've heard from other people of patients who've stopped for one reason or the other, and whether or not they do always recur?
I guess I haven't been brave enough to say let's stop, and I would say nor are my patients there. I think one scenario that does come up, and I would direct you to Ross Camage has, one JTO paper. We remember that these are oftentimes young patients. So ALK-positive lung cancer, sometimes decades younger than our typical lung cancer patients. So I have a number of patients in their 20s and 30s. And so fertility issues come up, right? And so that's a scenario where, the issue has come up of, hey, can I take a break from my targeted therapy? I would say that the last patient where this came up with me, this was someone who had already progressed on multiple lines of ALK inhibitors, and I was and the last time she progressed, she was in the ICU intubated, and I didn't think we'd be able to. I was worried about coming off therapy for that long because she had a combination of ALK fusion and MET amplification, and so not only was it kind of the disease was quite aggressive, it was also on double targeted therapy and the unknowns of the teratogenicity of our targeted therapies.
I imagine there must be people who come off therapy for toxicity, even if it's after a couple of years. Have you, or I don't know, maybe that doesn't happen, but any situations where you've had people come off therapy for toxicity even after a year or two, and then do they always get switched to another agent, or have any of these people been observed, and do they all progress?
Yeah, no, it's a good question. For IO, right, in that situation, I would probably just take a break. in this situation, because we have 6 approved agents, I've generally just switched to another targeted therapy. And for the patients who I'm thinking about, where I've had to shuffle through a number of agents, were very, very symptomatic at the time that they were first diagnosed, including with brain metastases, and have not been. It was all about let me get back on a different ALK inhibitor.
So another sort of related question is, what do we know about cell-free DNA in patients with ALK rearrangements? Well, I'll start out in the metastatic setting. I'm also curious about the localized setting, although today we're focused more on metastatic disease. Anything in general with lung cancer and specifically with ALK patients?
Yeah, a few key points here is remembering that the sensitivity of cell-free DNA for detection of ALK is lower than your point mutations, right? Or your single nucleotide variants. So EGFR, KRAS, the sensitivity of ctDNA is higher for those alterations. Fusions are more genomically complex. Um, some of the fusions occur within introns, right? And so developing, the commercial assays, tiling along those introns. So it's just more complicated to find fusions at the beginning. So, just because, you have a never smoker, you get the, non-diagnostic ctDNA report, you still need to wait on the tissue. And then the second, and it's related, which is that because the sensitivity isn't as good, the ability to then use that as a monitoring tool, it is also, it's lower, right? Because you don't have enough dynamic range to track the fusion. So Ibi Dagogo Jack had a nice paper now over 5 years ago in JCO Precision Oncology where she showed, you could find the ALK fusion at the time of starting an initial therapy. It generally cleared in most patients. So I don't think we can just use with the off-the-shelf assays, clearance of ctDNA isn't going to be good enough. We have an initiative right now through Breakthrough Cancer, a philanthropic organization, where we're trying to use a combination of exploring 2 different approaches. One is, can we actually take off-the-shelf assays, but integrating fragmentomics or methylation patterns to try to get a better dynamic range? Or can we actually develop tumor-informed assays and use the tumor-informed assays with a better dynamic range to actually use it to detect minimal residual disease? We don't know yet, but that's where I think we need to go.
So, any comments about the use of chemotherapy in metastatic ALK-positive disease? Both if you get to it, for example, a patient is resistant to ALK inhibition, what type of chemotherapy? Again, pemetrexed, is that better and why? And also, I got a real surprise when that trials came out looking at chemo plus osimertinib. I don't know. And then, now it's a valid option. Any thoughts about that kind of strategy with ALK?
Yeah. So I do think there is a role for chemotherapy, right? We saw from early publications that pemetrexed, is a, is an active agent for ALK-positive lung cancer. Like other kind of never smoking induced alterations, we definitely see increased activity of pemetrexed. If we go way back to Profile 1007, which was looking at the crizotinib versus docetaxel versus pemetrexed in the second line setting, pemetrexed was more active than taxane. in the control arm. So I do generally reach for platinum pemetrexed in patients where we've kind of exhausted our targeted therapy options. Would I pursue a FLAURA2 like regimen in ALK? I don't have much enthusiasm for it right now. One of the things about FLAURA2, if you look at, first, the median PFS with OC is shorter, right? We're talking about 18, 19 months. Lorlatinib, we just talked about, it's over 60 months. And then two, even with that relatively shorter PFS with OC, the median duration of pemetrexed in FLAURA2 is 9 months. So even though patients, were trying to, most clinicians were stopping it well short of their progression event. So I worry about the long-term tolerance. Maybe 4 cycles, just the induction, right, to help that early part of the Kaplan-Meier curve, but I would never continue the maintenance piece.
So another question that we've been asking for a while, I'm kind of getting the same answer, but just to check in, is the issue of immunotherapy, specifically checkpoint inhibitors. A lot of times I hear people say that it's just not on the table for ALK ever. Do you sort of go along with that approach in terms of that? And also, is there like some phenomena of, I don't know if you want to call it false negative high PD-1 levels that you see with ALK? And if so, why?
Yeah. So I'm in that never camp. I really never reach for checkpoint inhibitor in ALK-positive lung cancer. If you look at the response rates, the response rates with single agent are basically zero. There is a distinct biology of PD-L1 that I think is worth highlighting here. So normally when we think about PD-L1 as a biomarker for IO, we're alluding to so-called adaptive immune resistance. And what that is infiltrating CD8 cells, right, are secreting interferon gamma, and interferon gamma in the tumor microenvironment drives overexpression of PD-L1 on the cell surface, right? So it's a surrogate of interferon gamma and CD8 positive cells, okay? However, there's another way you can get PD-L1 expression, which is called innate immune resistance, which is that oncogenic signaling through the JAK-STAT pathway can drive PD-L1 expression because of the oncogenic growth signals. And in that context, right, you don't have infiltrating immune cells, you don't have interferon gamma, it's just the JAK-STAT signaling is causing PD-L1 expression. And so that's what we observed. So we published this in 2016, showing that for both EGFR and ALK, pre or post TKI, that even among those who have high PD-L1 expression, if you look for concurrent CD8 cells, they're not there. And so I think biologically, we shouldn't be fooled just by the PD-L1, acknowledging that many times we get that result back faster than we get the genotyping back.
So having spent a couple hours yesterday on a program of myelofibrosis, I got a lot of JAK inhibitors in my brain. Has that been looked at in solid tumors or lung cancer for this immune effect?
We have not. I mean, unfortunately, our use of JAK inhibitors in the thoracic world have been isolated to use for immune-related adverse events, treating myocarditis and other difficult-to-treat IRAEs, where you're already using first-line steroids and needing to add, that's usually where I'm reaching for a JAK inhibitor, but not as a therapeutic in ALK or other targeted therapies to date.
You use JAK inhibitors for autoimmune complications of IOs?
Yeah.
Which one?
So it in some ways we take what we're able to get on our inpatient formulary, and I know I'm not supposed to use brand names here, so ruxolitinib is our most
Use
common.
really? Well,
Yeah.
I can't believe I've never heard that. Is that commonly utilized?
So there's a growing literature now, yeah, in that, especially for things like myocarditis or refractory colitis or refractory kind of hepatitis. That's typically what we'll use.
That's really fascinating. Another question I have is, in general, in patients with ALK metastatic disease, we'll get to CNS in a second, but what about local therapy, radiation, or surgery for oligomets? How often does that happen? What locations? And how effective is it?
So we certainly want to approach oligometastases and we're quite aggressive in using I would say more radiation than surgery for patients. And if it's oligo progression, we will certainly reach for radiation early. I would say that now some of the questions in the field are, should we actually be using consolidation therapy even if someone's not progressing, with the hypothesis that the known sites of disease are going to be the most likely to grow. So Henning Willer's, Alicia Sequest in our group showed a couple of years ago that about 2/3 of the time in patients with EGFR positive lung cancer, progression occurs in the original sites of disease. And so what we've typically done is, treat to best response. And then if patients have a few sites of disease, we'll think about local consolidation radiation therapy in that context.
Really interesting. Another thing that you said, which again, it's amazing how many times we've done ALK programs, and I don't know, it just never got through to me, was that how bad the untreated prognosis is. It kind of reminds me of in a HER2 positive breast cancer, which originally was thought of because it had such a bad prognosis. Now people want to have it because you have so many targets. Does that apply mainly because of the CNS mets, or also systemically it's more aggressive?
It's systemically more aggressive. And I think that what we've seen is, it's kind of hard to tease it apart, right? But it's definitely got a more pro-metastatic phenotype. So, it's rare to find stage 1, stage 2 lung cancer. Now, it's a little tricky to do those analyses, right? Because you may be missing them because they're younger. But nonetheless, I do think that there is this stage shift where it's very unusual to have stage 1, stage 2 ALK, that they typically present more stage 3, stage 4 disease.
So let's talk a little bit more about CNS disease, or at least in the brain. And then I'm going to ask you about leptomeningeal disease as well. But in terms of the brain, can you talk about how you use local radiation therapy, SRS, but also whole brain, how often you have to do that? How do you do whole brain? And, do you use SRS in patients even if they have a great response to systemic treatment?
So we try to avoid whole brain like the plague. You should never, ever, ever, ever be doing upfront whole brain radiation for ALK positive patients ever, right? And because we're now seeing, we're talking about 5-year survivals, right? Over, just progression-free survivals, right? And we've all seen those patients, right? Years after receiving whole brain radiation, and it's a dramatic impact on quality of life. So, I would say that, it really underscores speed of testing. In our practice, we send both liquid and tissue simultaneously, because the liquid usually will come back faster. And, in a never smoker, we'll consult the radiation oncologist, but our radiation oncologists know that, if, you know, I'd much rather resect something, right, than start doing radiation up front. So if someone is so neurologically, where we need to make a decision within those days, then usually we're just sending them to the OR for a resection, and we're keeping the radiation in our back pocket. It's not wrong if it's going to be 3 weeks for you to get the testing back, but ideally we would focus just on targeted therapy, because we know that the intracranial response rates, right, are 80-90%, and it's going to work faster. It's going to be work faster than radiation. So in our view, targeted therapy up front. Jessica Lin had a nice paper a couple years ago where she looked at, brain metastases 2 centimeters greater or symptomatic, and showing, the activity of alectinib in that context. So, even big bulky brain mets, if they have a fusion, I try to do targeted therapy, unless there's a role for surgical resection.
Anything different about brain mets with ALK compared to EGFR or even patients without a target? For example, the presence of edema and sensitivity to corticosteroids is about average, or you see more edema?
I don't think there's much of a difference there. One thing that you can see is you could see more cyst-like brain metastases. There are some patients who develop it's all cystic, and so it can create more mass effect, right? Because they're cystic. But when you come in with targeted therapy, those can have very, very rapid responses. That's the only difference that I've seen. We reported a couple years ago. You can also see some strange sites like medullary metastases in ALK. Fortunately, again, our drugs have gotten very, very CNS penetrant and respond well, even in that setting.
Any comments about leptomeningeal disease in patients with ALK?
Leptomeningeal disease is always hard, right? But we've certainly seen that with our ALK inhibitors, these patients can have terrific responses. And I would say that ALK has been at the forefront, in lung cancer, in the sense that now many of the clinical trials will even allow leptomeningeal disease. There will be some guardrails around symptoms, but not many lung cancer trials, right, allow leptomeningeal disease on the study. But we do have a number of ALK trials now that do permit LMD. Which is great. I think that's a step in the right direction in recognizing that when you have a highly CNS penetrant drug, we shouldn't be excluding those patients.
So I want to ask you a little bit more about lorlatinib and your experience with tolerability there. A little sort of an amusing anecdote I think maybe you'd appreciate. When you put up the slides for progression-free survival with the CROWN study, I was flashing on the fact, you have your GU colleague there, Matt Smith. You know Matt?
Yep. Yeah, of course.
Matt created, I don't know if you know this, probably not, created a name called the Pelican graph. Have you ever heard of that?
No.
Right. Okay. So there was a study done in prostate of M0 disease looking at more aggressive hormonal therapy, and they added enzalutamide and LHRH agonist. And when Matt put up the picture, it was the typical drive-through, same thing with you just saw with CROWN. But then he put a picture of a pelican on top of it with the beak open. So he calls those pelican graphs. So now we like to joke with other parts of oncology. Yeah, the goal here is to get a pelican graph. It looks like you guys got that there with at least with lorlatinib. Anyhow, but again, the issue is tolerability. I wonder too, like, we really should survey oncologists, but my sense is that maybe there's a lot of concern or nervousness about using lorlatinib, because when we first started hearing about the CNS effects, I think everybody was like kind of surprised. I certainly was. Can you provide a little more granularity and maybe reassurance to people about using it? We'll look at the survey because obviously the investigators are certainly using it. But in reality, how challenging is it to deal with the CNS issues?
So in reality, I think these are very manageable. So in where that starts is first, I think you have to set expectations with patients and really have an open and honest conversation. If you ask me kind of to look at toxicity tables, right, your eyes gloss over, right? It's hard to really put them into context. But when I talk about the toxicities, I tend to talk about like the different waves. Like, okay, in the first 3 months, this is what I would expect to see. Okay. And then in the next, 2 years, these are some of the side effects that we're looking at. And just for them to start gauging. So the neurocognitive effects, these are usually you see in the first kind of days, weeks to months or two on the drug. So this is early. Um, it so you want to lay the expectation. You want to tell the partner too, hey, this is what we typically see. The FDA label, right, is to start with 100 milligrams. If I'm worried about somebody or they are worried about themselves and how they may tolerate it, I actually will sometimes start with 75 milligrams. Now, the reason why is, we haven't done a good job, right, in oncology of identifying the optimal dose of targeted therapies. And remember, lorlatinib was first approved in the second line setting where the goal was to try to overcome that G1202R mutation, that resistance mutation. And if you look at the IC50 of G1202R versus wild type, it's 20 times higher. You need a 20 times higher IC50 to overcome G1202R versus wild type. And so in a naive setting, right, you probably don't need 100 necessarily. Now, we'll generally start people there, but if someone is concerned or I'm concerned, they have some issues to begin with, they're older, I'll start at 75. And I would expect, one difference between alectinib and lorlatinib is it does require a little bit more upfront kind of back and forth with the patient. It does require a little bit checking in more, or the patients may be calling into the office more. But I think it's worth it, when you look at those PFS curves. So, and if people are experiencing some of these effects, usually I'm having them pause, hold for a couple days, always gets better. And then we talk about, do we restart at the same dose or do we dose reduce?
So when you were talking about how you prepare these patients as flashing, we actually, like for example, the Oncology Nursing Society we go to every year, our theme is usually what I tell my patients. And I'm curious, literally, what do you tell your patients about these CNS effects specifically? Like, do you actually come up and say, you might have this happen? And what do you give as examples?
Yeah, no, I give very concrete examples. Examples from my own patients, and so I give examples of, it exists on a very large spectrum. So on one end of the spectrum is the subtle stuff where you may not even notice it yourself, that your partner may notice. I had one patient who thought everything was great, right? But her husband said she kept yelling at the dog, and that was really
Wow.
unusual, right?
Hmm.
She didn't even think anything was wrong. There was another patient where she also thought things were fine, but it was just a little bit more or less patient with the kids. Really subtle. So you need to have ask the partner too. I've had other people where they described where it was occasional word finding, where, hey, doing the New York Times crossword puzzle is just taking me longer, right? I just couldn't isolate that word. I've had some people. I have a lawyer who described usually she'd work on 2 monitors, and she had it. It was really difficult to manipulate both monitors. It was the multitasking. The rest of her life was was unaffected. It was just doing it at such a high level that's really where it started kind of being more of a pressure test. There are other people where it's feeling like, hey, it's like I had a cocktail. Like, my brain just wasn't super sharp. To all the extremes. I've had patients, early on. I had one patient who, now this was in the early days, right, where patients had a lot of brain radiation, had a lot of surgery, right, had history of seizures to begin with, but called and told me that was on the plane and thought they saw animals on the wing, right? Was having some visual hallucinations, and that's like a one isolated episode, and I think that it was the combination of drug plus had baseline all the radiation effects, and then the last is I've had one patient who developed some suicidal ideation on therapy. She knew she was having it, and called us about it. And we did have her evaluated by psychiatry. But that is one of those rare ones that you'll hear about. And so I do bring it up to patients too, and talk about how rare it is, but that we want to know, if there's any changes in mood.
So, any other? I think the examples that you gave are really, really helpful. Any other examples? And everything you've talked about so far sounds almost kind of like mental processing. What about sort of focal abnormalities, cranial nerve palsies, or
Yeah.
neuropathies, or anything? It's all like sort of processing kind of thinking.
Process, you can see peripheral neuropathy, and my experience has been that there are a couple people, and it almost feels like it's some of these long-term responders, the response, like folks who have been on alectinib for 13 years, who are very, very who have some peripheral neuropathy. Remember, ALK, can be expressed in neural tissue, and I don't think we fully understand all, kind of so could this be on target effects causing some of that neuropathy? So it is something that people. It's usually peripheral neuropathy. It's usually bilateral. It's usually symmetric. We can certainly see.
When you do dose reduction for lorlatinib, what's the usual reason?
It's usually the neurocognitive effects. If
Right,
I'm going to dose reduce,
right.
for I will never really dose reduce for cholesterol. I'll up titrate things. I also think the weight gain. It's not something that I've typically dose reduced for. It's more I've tried to get people into the weight center. That is something we've seen with alectinib too. And so for some of my folks who had started on alectinib, making those same referrals.
I was going to ask you about the weight gain in terms of sort of the pathophysiology or how it plays out. Do they exercise less, for example, or any idea about why they get weight gain?
Yeah, for many people, it's many of my patients with weight gain are actually exercising a lot. They're very cognizant of it, and so
Hmm.
they are on their exercise bikes. They're going on their walks. It is, and it feels like My experience has been that no matter how much you do that exercise and cut down on your diet, it's the drug, and that will only take you so far. If anything, it will decrease the slope by which you are gaining weight, but it's very hard to actually decrease the weight.
Does it affect basal metabolic rate?
I don't think we have a lot of understanding of this so far. There have been a couple studies looking at, can you actually measure adiposity using the CT scans, right, serially, and how does adiposity change? You definitely see an increase in central adiposity, um, but I don't think we have a great understanding right now.
So one more question before we get to the survey. What do you do in terms of allowing patients to drive a car on lorlatinib?
Yeah, I mean, if someone's never had a seizure, um, it, I would say that there aren't major restrictions, except for I want to have a good understanding of those neurocognitive effects, right? Early on. So, is someone having any of those? Like, if so, what's the nature of it? Is it affecting kind of decision making time and things like that? Much like we have conversations with our patients about this, right? With brain metastases, right? Or you know. Typically engaging our neuro-oncology colleagues. So those are some of the things. But usually, after I see patients actually quite frequently in the first 6 weeks. Usually, I'm seeing them every other week, either me or my nurse practitioner. And I would say after that first 6 weeks, that early, like you have a pretty good understanding of where they're going to land on the neurocognitive effects. And so, I think that gives you a pretty good indication.
So let's go through this survey. I'm going to show you a bunch of what in our group we call them BTG slides, beyond the guidelines. Because guidelines, they give you three or four
Yep.
options or evidence base, et cetera. We just go right to the heart and ask the same people, well, what do you do in your practice if you don't put people on trial? We got a pretty good group of people here, as you can see, to answer those questions. I think these are the questions oncologists have. The issue of what kind of testing to do. Obviously, RNA testing is a critical issue here, as it is with RED and other situations. To me, I think if you put together what we saw here, people want to see NGS, DNA, and if that's not positive, RNA, and sometimes people send both. But one way or the other, it seems like, I don't know if this is just for non-smokers or for everybody with non-squamous. Do you think that everybody with not, even if they're smokers, should have an RNA-based assay also?
I think if you don't have evidence of an actionable alteration, right? If which ends up being a smaller percent, right? So if you have a KRAS, most of the time you're going to find something else, KRAS, some other driver. But in the absence of another driver, then yeah, you want to be we know smoking status isn't a perfect surrogate, so it can be transformative for a patient to find something.
So, getting again, the way we do these beyond the guideline things is if all or almost everybody says the same thing, we call that a consensus. A lot of times we ask people questions, we see equal division among three or four different choices. We know there's not a consensus there. So it's kind of simple, but it seems to work. So it's interesting when we ask about first-line therapy, almost everybody says lorlatinib. A few people are sticking to alectinib. Just out of curiosity, I imagine this comes up, in discussions you have with your colleagues, ad boards, et cetera. What do you think people are thinking who are still using alectinib?
Yeah, I mean, I would say that the most common reasons I've heard are, one, well, people will point to an anecdote. Well, I've had a couple people who have done really, really well on alectinib for a long time, and I have too. It's just on a population level, right? We see that the lorlatinib data looks, you know, it's going to be longer, um, based on the Crown data. So I think that and uncertainty, like on what to do after, and then three, it's no doubt that alectinib is as close as you get, right, to starting a drug and not having to do much in the way of modifications with patients, right? High response rate, people feel well. The challenge is, the median is at the 3-year mark, and then we know that the biology can change.
We see this all the time, a few sort of stragglers who take, a couple years to come over, but usually we keep following and we see that kind of goes away. We'll see if that
Yep.
happens here. This is another question we were asking. You can look it up in the literature, but you can also ask people with a lot of experience the question of, what fraction of people present with brain mets, and obviously a pretty significant fraction, which I think nobody's surprised about. I think also people, it's interesting too, throughout oncology, people are always having to make indirect comparisons all the time. There's so many great new drugs out there. And sometimes, you kind of look at it a little bit and go, that's a little bit close there. But then there are other times like here where it's a lot easier, even though it's indirect, to see what's going on. So I think most people think it has more CNS activity, more activity in general. But also the question of tolerability, I guess a lot of people still think that alectinib, as you were sort of referring to, is the most tolerable as well. But I don't know if that sort of reverses what you see in terms of efficacy. So when we get into different scenarios, we say a younger patient, most people say lorlatinib. We also brought up, even more people say it if there are brain mets that require whole brain radiation. You were talking about how you try to avoid that at all costs. Same thing with stereotactics, still lorlatinib. What about the issue of patients with diabetes, particularly poorly controlled? You see a few more people thinking about alectinib. I wasn't even really sure why.
Yeah, I mean, if you look at the rates of hyperglycemia in the um, Global Alex and Crown, they're pretty comparable. If anything, a little higher with alectinib. Um, rates of grade 3 or higher hyperglycemia, pretty comparable as well. I think what people are probably reacting to is concern about weight gain, and the weight gain making the diabetes
Right.
worse is probably what I'm thinking about. But as I mentioned, with alectinib, you also get weight gain. In fact, there was a nice study where I alluded to it, where they used CT scans and they measured central waist circumference, and the median increase in waist circumference after 1 year on alectinib was 10 centimeters. It's not trivial. 10
Wow,
centimeter
that's a lot.
increase in waist, right? So I think that, for me, I think with either agent, we're going to have to be on top of it, because of the concern for the weight increase.
Yeah, I think most people would rather gain weight than get brain mets. But anyhow, another question that sort of is obvious, Deb, is the history of psychiatric issues, whether we said anxiety and depression here. Still, most people are saying lorlatinib. A couple of people flip over to alectinib. We could say the same thing, patients with a prior history of stroke, any kind of psychoses on antipsychotic medications. Any comments in terms of lorlatinib and these kind of spectrum of these comorbidities?
Yeah, I mean, I think this is where I really would want to take a careful history, and including picking up the phone and calling their psychiatrist, right? Of like, how worried should I be? And having that conversation, and many times, you can either be reassured, or oh, my uh, no, I actually think we need to change course here. So I think taking a good mental health history, have they been on certain agents, admissions for it before, history of suicidal ideation, admissions for that, um, and when was the last time they've seen their psychiatrist? Do they have steady contact? Those are things that I'd want to know about before. Again, I don't think it's an absolute contraindication to using an agent like lorlatinib. But I think you want to go into it prepared and having done your homework.
When you talked about this issue of trying to educate the partner or family member or friend, it kind of reminded me with CAR T. They were also looking for people in the family to keep an eye for ICANS. What do you do if a
Exactly.
patient has no connection, totally isolated, no family? You just try to follow them more carefully.
It's a good question because there you're a bit torn, right? You don't want to deprive someone of what you think may be a better therapy, right? But you also recognize that those are also not the side effect is going to preclude their ability to report it to you, possibly. And so there, I'd want to know, like, do they have a history of baseline anxiety, depression? Maybe I would start that person if I was, if I thought no, that they didn't have a history, then I'd, maybe start them at 75 and maybe see them once a week, right? And the trigger being if they're not showing up, okay. So that's probably how I'd approach it. And people where I'm really concerned, I'm also looping in our social worker. I'm seeing with our NP, so that they have multiple sets of eyes seeing them and knowing what baseline is.
Congenital long QT syndrome or pre-existing bradycardia. Again, it doesn't seem like it changes the thinking much, but any cardiac considerations in selecting an ALK inhibitor?
Yeah, I mean, if you look at the label with alectinib, you'll see, things about QT and bradycardia. Even with lorlatinib, you'll see them talking about AV blocks. It's uncommon, and so we've also saw that with crizotinib too. So, this for me wouldn't steer me away. I would generally do lorlatinib in that context.
Pre-existing hypertension, particularly if it's difficult to control, is that a factor?
No, I mean, we're going to be seeing them often enough where we can work on the blood pressure. So that's not going to steer me one way or another.
Chronic renal disease, even dialysis. It looks like people are still using the lorlatinib.
Yeah, I mean, I think with the caveat that, for all of these agents, right, we don't have a lot of data for their use in CKD, HD, all those things. But, that to me wouldn't alter my first line choice.
So this one kind of surprised me. We always throw in, 80 or 90-year-olds. In this case, we said 80.
Yeah, and I think this is really where I'd be curious, the question stem versus like the patient in the room with you, and where there are many different types of 80, right? How does this person look? You is there some baseline cognitive dysfunction, and having an open and an honest conversation about that. So to me, the age, we always have a left digit bias too, right? I think if I'd be curious if you did the question and you said 79, right?
Right.
So, to me, that wouldn't make a huge difference unless, it's more the functional age of, does this person have some baseline cognitive dysfunction? Is it affecting their day-to-day life? Is it affecting their ability to do their finances? Is it affecting their ability to work or do other things? That, gives me a much better readout of because, I know I can change dose if I need to.
This is interesting. We're just curious. You mentioned the issue of suicidal ideation, and we asked them if they'd seen it. Actually, a number of people actually had seen that. Have you actually seen that in a patient? Have you had a patient actually commit suicide? Have you heard about
I've
it?
had a patient with suicidal ideation requiring admission. It was one since I've used it, so over 10 years, but one.
And then for grade 2 or 3 CNS side effects, including confusion, concentration, or mood swings, how do you usually manage that in terms of dosing? Do you hold the dose? Do you decrease the dose? What do you do? Looks like most people discontinue or hold it and then restart at a lower dose.
Yeah, that's exactly what I do. Hold and then resume at one dose level lower.
We asked also about interstitial lung disease. Do you actually see interstitial lung disease with the ALK inhibitors? Do you see more with lorlatinib? And again, if you do see any even asymptomatic grade 1, what do you do?
It's an uncommon AE. This is not something that we see a lot, and so you know, I'm not jumping to, hey, this is IL. This is not like trastuzumab deruxtecan where we see higher levels. And so usually, I'm taking a history of any infectious symptoms, and so I'm not quick to jump on the ILD train there.
So, any comments about patients who've gotten adjuvant alectinib and how you approach them if they develop disease progression, either on the alectinib or after receiving it?
I think if it's on alectinib, then we would take the approach just like we would in the metastatic setting, that they are resistant, and I'd think about lorlatinib there, understanding that the likelihood of response is going to be lower. If someone had a time, completed their 3 years, and now it's another 3 years has gone by, that's likely going to be a different scenario. And I think you would have options there of a second generation inhibitor or lorlatinib. I would expect that to have a better outcome, right? Because it's really just being off the targeted therapy.
So, this is something I thought was very interesting, that while the most common approach to a patient who's with progressive disease on alectinib is lorlatinib, the most common approach to the patient with disease progression on lorlatinib is chemotherapy, which is kind of a statement about relative efficacy of lorlatinib and the other ALK inhibitors.
Right, right, and that's what I would answer too. I would say chemotherapy.
Anything you want to add? Anything we've talked about today in terms of metastatic disease? Anything, any myths or misperceptions out there you might want to correct?
I think the other thing is, you still want to surveil the brain. So it's not just like initially at the time of diagnosis. You do want to periodically be checking MRIs. And for me, if they're on a second generation inhibitor, it's every 6 to 12 months. If they're on lorlatinib and they don't have any brain metastases, I still do it once a year.
Any other ALK inhibitors coming along? Do you envision the possibility of a super lorlatinib that's actually, I don't know, better kinase? I don't know why, or I assume it has to do with the kinase spectrum. Can you imagine something that might be more effective, or do you think we'll need a completely different class of drugs or something added to it?
Yeah, so there is a compound currently being made, and that's shown some activity, including among compound mutations. What Aaron Hanna's group has shown is that it's hard to have one TKI that's able to overcome all compound resistance mutations. There's a group that overcomes the G1202R based ones, and then one group that overcomes the I1171, but no one that overcomes all of it. So the NVL compound has shown some encouraging data, and so that fourth generation inhibitor is still an active investigation.
So again, we're talking about metastatic disease here, but just because I would just want to update myself on where things stand in terms of your approach to adjuvant ALK inhibition. Do you add chemotherapy? Also, locally advanced unresectable, and a patient is going to get chemoradiation. Would you follow that up with? And are there trials looking at or lorlatinib in those two settings?
Yeah, so my answer is in someone who's had surgically resected disease that's node positive, I do give chemotherapy, and then I consider adjuvant alectinib based on the label. And also when you're talking about adjuvant, right? Tolerability is important. In patients with locally advanced disease, unresectable, who get chemoradiation, I right now am extrapolating from the LAURA data that showed the benefit of adding EGFR TKI there, and so I actually have thought about, if I was in that situation, I would give ALK TKI.
And then are there trials with lorlatinib?
Not that I'm aware of.
Do you think there's not going to be trials because, and if so, is that because we already have hit the ceiling, or because they're worried about CNS, or what?
You mean adjuvant studies or
Yeah, adjuvant
consolidation?
and both.
Yeah. I think adjuvant studies take so long to accrue to and read out. So if I were driving the show on development, it wouldn't be my absolute priority. I think local consolidation therapy or kind of consolidation therapy after chemo rads. I do think we, as a field, it would be nice having data in a second oncogenic driver to show that that's really the paradigm that we should be pursuing. So I would want to see some data in ALK there.
This concludes our program. Special thanks to Dr. Gainor, and thank you for listening. This is Dr. Neil Love for optimizing the selection of first-line therapy for patients with metastatic non-small cell lung cancer and an ALK rearrangement.